Welcome to Safe CT Practices 2019. This module is designed to meet the annual CT safety and dose optimization technique requirements required by the Joint Commission. After completing this module, you will be able to discuss the role of the computed tomography technologist in reducing radiation dose, including technical factor selection, positioning, and shielding. Discuss special considerations for pediatric patients. Describe ethical considerations including the overuse of CT, appropriate imaging of pediatric patients, and how protocols can affect scanning. List techniques used to ensure patient safety, including protocols, venipuncture, and contrast administration. Explain the importance of image gently and image wisely. Demonstrate emergency procedures. Medical professionals want to do what's best for their patients, but we don't always agree on what that is. If you ever have a question about why a test was ordered or how to go about getting the best scan possible, you must try to get the answers to your questions. You aren't helping your patient by making assumptions or guessing the best course of action. Overuse of medical testing is an important issue. Part of the job of the CT technologist is to provide the physician all the pertinent facts concerning the patient, including the number of scans the patient has had in the recent past. Be sure to inform the physician or radiologist if your patient has undergone several scans of the same body part for the same reason. There may be other, more appropriate tests that provide the same information but deliver less radiation. The American Society of Radiologic Technologists, or ASRT, has developed practice standards that define what constitutes acceptable practice in computed tomography. The Clinical Performance Standard concerning assessment states that the CT practitioner reviews the patient's medical record to verify the appropriateness of a specific exam or procedure. If you believe that the examination is inappropriate, you are well within your scope of practice to query the ordering physician or radiologist about the exam. The as low as reasonably achievable principle, or ALARA, still applies in computed tomography. You can follow ALARA in a variety of ways. Patient education. Just as in diagnostic radiology, patient education is key to reducing patient exposure in computed tomography. If you make patients aware of the importance of staying still and of following breathing instructions, you will have fewer repeated exams due to motion artifact. You must be willing to ask patients personal questions. Simply inquiring if there is any metal on his or her pants is not enough. You must ask about any object that can affect the scan, such as body piercings, hearing aids, and removable dentures. You do your patient a disservice if you have to repeat a scan because you forgot to adequately screen for certain items. Physician education. Although you might not believe you have much control over the type of examinations ordered or the reason for the exam, you should understand your facility's protocols and bring them to the attention of the ordering physician. Often the physician might ask you what the appropriate test is for a specific patient. Your radiologist is the best source of information for these types of questions. Positioning. You should always take the time to properly position your patient. If your patient is not centered to the X, Y, and Z axes, there's increased dose to the patient while the tube compensates. Misalignment of the patient also can cause excess noise. For example, positioning plays a large part in reducing dose during a CT scan of the head. If the patient's chin is tucked towards the chest, it reduces any gantry tilt needed. Therefore, you have a better chance of missing the eyes because gantries have a limited degree of tilt. Shielding. There are two schools of thought regarding shielding in CT. One position dictates that shielding is always necessary for overall safety and patient peace of mind. Another theory holds that a misaligned shield could allow the X-ray photons to scatter underneath the shield, causing potential harm without providing any usable information. It's a judgment call for each technologist and institution. If you decide to shield, remember to do so a full 360 degrees around the patient, because radiation comes from all directions in CT. Technical factors. Remember those math calculations you had to perform in radiography to adjust the kilovolt peak or kVp and milliampere seconds or mass for changes in the source to image distance, grid ratio, and other technical factors? The good news is that the CT scanner does the calculations for you. The bad news is that you can't always trust a computer to reduce patient dose. Each series in a full scan needs to be tailored specifically to the patient on the table. It can be a daunting task to take so many factors into consideration, but let's look at the best ways to use each one. Just as in radiography, kVp controls the ability of the beam to penetrate tissue, so is used to adjust the contrast in an image. Increasing kVp for an obese patient or bony joint results in a decrease in noise on the images. Generally, the range for CT is 100 to 140 kVp, with stations increasing in 20 kV steps. When using MA modulation, increasing the kVp station also may increase the MA station, something to consider as you change scan parameters. The technical factor, milliampere seconds, or mass, controls the number of X-ray photons produced by the tube. An increase in mass results in less noise in the scan, but an increase in patient dose. It's a delicate balance between using enough mass to create a good image and not over-irradiating the patient. CT scanners use a type of automatic exposure control known as milliampere or MA modulation, although the exact name used depends on the manufacturer. For example, GE scanners use the term auto-MA. Siemens scanners use the term care dose. MA modulation can work in several ways, depending on the specifications of the CT scanner. For instance, on GE equipment, it can be adjusted based on the AP and lateral scouts, or, for Toshiba scanners, based on a single image. As the images on this page demonstrate, the CT technologist changes the MA based on body habitus, body part composition, or the thickness of the body part. For example, the MA used in image A is lower than image B because patient A has a smaller body habitus than patient B. In the same way, image C shows that a lower MA is used to produce an image of the lungs than of the abdomen because X-rays can penetrate the lungs more easily. Image D shows that a higher MA is used to penetrate the thicker lateral projection of the patient than used for the thinner AP projection. The CT scanner's computer automatically adjusts to the preset parameters without your input. Just remember that these automatic parameters don't always result in the lowest dose to your patient. The easiest way to understand pitch is to imagine your patient on the CT table surrounded by a spiral. When the pitch equals 1, each spiral touches the next spiral. If the table moves 10 millimeters for every slice and the scan is acquired at a 10 millimeter slice thickness, then the pitch equals 1. Increasing the pitch to 2 means that the table moves 20 millimeters for every 10 millimeter slice. The spiral now is stretched out to twice its original size, which cuts scan time in half, but also means some data is missed. This sounds unreasonable. Aren't you scanning the patient to get the best diagnostic study possible? True, but increasing pitch on localized scanning, or for studies in which one-to-one slices aren't required, can avoid unnecessary radiation to the patient. The reverse is true when you want the slices to overlap to get the most information possible. This involves adjusting the pitch to less than 1. For example, CT angiography is extremely useful to diagnose emboli, aneurysms, and other abnormalities and is usually performed with a pitch of less than 1. The computer receives enormous amounts of information that can be used during post-processing to demonstrate every possible piece of tissue. Dose rates for these studies are obviously much higher, but generally, the benefit outweighs the risk of these circumstances. Collimation in CT is not the same as in radiography, where the radiographer adjusts the size of the primary beam. In CT, the scan field of view, or scan FOV, is set for each protocol. When planning the scan using a scout image, the CT technologist generally adjusts the display field of view, or display FOV, while the scan size stays the same. The patient is not spared any radiation by adjusting the display FOV. So you should consider using a larger display field of view to include all the required anatomy when you reconstruct images. Remember that you must have scanned the anatomy and acquired sufficient data to reconstruct the images you need. Therefore, adjust the scan field of view to minimize radiation exposure to the patient. Just don't cut out any anatomy at this point because you can't get the data back. Gating is a technique generally used for coronary or pulmonary angiography studies. With gating, you synchronize the scan with a specific cardiac phase to get the most from the study without having to re-inject the patient with contrast. An electrocardiograph or small contrast bolus is used to identify when cardiac function is optimal or certain arteries are brightest. One study suggests this practice can reduce patient dose by up to 70% without any drop in diagnostic quality. CT scanners usually are described in terms of the number of slices, for example, 16 slice or 64 slice. What the number actually refers to is the largest detector configuration of the scanner. Most current scanners are able to scan large volumes of tissue in a relatively short time. This capability is the result of a curved detector array that can receive information from a fan beam while the array or beam or both elements move about the patient. Let's look at a 16-slice scanner as an example. This scanner uses an array of 4 contiguous detectors. Each detector scans 1/4 of its width 4 times, so 4 detectors, each of which scans 4 widths, equals 16 slices. A configuration of more detectors equates to a higher patient dose. The real benefit of CT technology is versatility. A true diagnostic coronary angiography study requires at least a 64-slice scanner, or 16 detector rows each scanning 4 widths. However, that same scanner can be reconfigured to be a 16-slice scanner for a kidney stone study. In this case, 16 detectors combine all information into 1 width each. One of the biggest challenges for a CT technologist is scanning a baby. Infants not only kick and scream, but their nervous parents may think that you're harming the child. Remember that your primary responsibility is to the patient, and that means getting the best scan possible with the least amount of radiation exposure. Although the use of immobilization devices can be beneficial, they may be disturbing to a non-professional. Make sure you fully explain to the parents the benefits of using immobilization devices. If parents insist on remaining with their child, allow only one in the room during the exam, because 2 adults can distract the child and ultimately cause motion. If someone has to hold the pediatric patient during the scan, make sure the individual removes all jewelry from his or her hands. There's nothing worse than getting an otherwise good scan of a baby but having artifacts from the mother's ring. It is also important to ensure that whoever immobilizes the baby in the room is properly shielded. The most important thing to remember when scanning pediatric patients is ALARA, or keeping the dose as low as reasonably achievable. Following ALARA means using pediatric protocols when appropriate and modifying technical factors if necessary. To promote responsible practices in pediatric imaging, the Image Gently campaign was developed in 2007 with the objective of raising awareness about methods to reduce radiation dose during pediatric medical imaging exams. The campaign is an initiative of the Image Gently Alliance, a coalition founded by the Society for Pediatric Radiology, the American Society of Radiologic Technologists, the American College of Radiology, and the American Association of Physicists in Medicine. Pediatric patients are at much higher risk than adults for radiation-induced illnesses, such as cancers. In general, children have a longer life expectancy than the average adult. Therefore, children have more time to accumulate a higher lifetime dose than adults. So what can CT technologists do to protect their pediatric patients? CT scanners have built-in pediatric protocols, but you can always change scan parameters when appropriate. Adjust KVP, mass, pitch, and other technical factors as necessary to match your patient. The Image Gently website, www.imagegently.org, has many resources to help build protocols for your equipment. plus charts to help you adjust scanning parameters on a per-patient basis. You should consult your medical physicist to help develop protocol for your facility. If you have questions about multi-phase scanning, talk to your radiologist. For example, you might wonder if pre-injection or delayed imaging is truly required. You might question if it's necessary to repeat the entire scan if the patient moves during the exam. Use all the resources at your disposal to ensure the best quality images with the lowest possible dose for all your patients, but especially for your pediatric patients. Just as Image Gently focuses on dose reduction for pediatric patients, Image Wisely is focused on adult medical imaging. Image Wisely is an initiative of the American Society of Radiologic Technologists, American College of Radiology, the Radiologic Society of North America, and the American Association of Physicists in Medicine. Its objective is to lower the amount of radiation used in medically necessary imaging studies and eliminate unnecessary procedures. For more information on Image Wisely, please visit www.imagewisely.org. True and insurmountable contraindications to the contrast used for CT are rare. Most problems can be overcome with preparation and planning. Allergies to iodine or other medications can be handled using a steroid preparation approved by your facility. Nausea and vomiting that prevent the administration of oral contrast can be controlled by medications or, in extreme cases, by the use of a nasogastric tube. Nephrotoxicity is a contraindication and possible side effect that is becoming more common with the increasing use of CT exams. Methods to avoid nephrotoxicity include extra fluid intake or pre-medication using acetylcysteine, although it's unclear whether pre-medication is helpful. Freestanding facilities and hospital radiology departments have institution-specific policies and protocols for injection. These guidelines can vary widely based on several factors, including the type and amount of contrast and the patient's age, gender, and laboratory values. Other contraindications include asthma, multiple myeloma, pheochromocytoma, certain thyroid diseases, sickle cell anemia, and myasthenia gravis. Contrast reactions in patients with these diseases vary, but in general, an injection of contrast aggravates the condition. Yet the benefits of CT often outweigh the risk to the patient, so if there's questions about contrast administration, you should consult the radiologist. There are several questions that CT technologists should ask when preparing patients for contrast administration. These questions often are site-specific or are required for the radiologist setting the protocol for the scan. Contrast media also varies, which might require the technologist to omit or add a question. Before contrast administration, the CT technologist might ask whether the patient has a history of allergic reaction to contrast, or if they are aware of any allergy to iodine. Other questions cover the potential for renal insufficiency due to nephrectomy, renal transplant, or end-stage renal disease that requires routine dialysis therapy. Lastly, in some circumstances, it is important to know if the patient is diabetic or currently taking metformin, also called glucophage. Questionnaires are site-specific and are written by a team of radiologists, technologists, and radiology nurses to meet the needs of the patient population. After starting the injection, the IV site should be monitored as long as possible before beginning the scan. No matter how good the IV line is, extravasation can occur at any time during the injection. Extravasation is when the contrast leaks into the surrounding tissue instead of flowing into the vein. Stop the injection immediately if this occurs and call for help if necessary. There are competing theories about how to treat extravasation. A cold pack can be used to reduce swelling. However, a hot pack helps dissipate the contrast by reducing viscosity. Regardless of how it is treated, extravasation can be a serious complication for the patient. A radiologist might need to be present to assess extravasation in more severe cases. Even if you take every available precaution, extravasation can cause ulcerations compartment syndrome, or tissue necrosis. Make sure to properly document all cases of extravasation according to your facility's safety guidelines. Patient preparation for CT can vary widely depending on the protocol, diagnosis, and contrast used. Most institutions require patients receiving IV contrast to be on a clear liquid diet or take nothing by mouth or NPO. Bowel preparation can include barium or iodine-based oral solutions and even rectal contrast administered 1 to 4 hours before the exam. You should ask if the patient has undergone any other CT or radiography studies that required bowel prep within the past few days. The barium used for a regular fluoroscopy study is more dense than that used for a CT exam. It causes streaking on CT images and could possibly ruin the study altogether, particularly non-contrast studies such as a kidney stone protocol or spine exam. In that same vein, check each patient's diagnostic testing orders to determine if the CT scan needs to be scheduled around other modalities. For example, patients often need to be NPO for an ultrasound or nuclear medicine study. Make sure to remove any metal located within a few inches of the area of interest. Remember that just because the object isn't located in the display field of view doesn't mean that it won't affect the final images. Reconstructed scans, such as the spine, are particularly vulnerable to beam hardening from artifacts within the scan field of view. The CT technologist is responsible for verifying the patient's history, including all allergies and medications. Follow your institution's guidelines regarding steroid preparations for iodine allergies and post-scan procedures for patients on certain medications. You are the last line of defense for your patients, and their well-being is your responsibility. The drug metformin is an example of why it's important to verify the patient's medications. Metformin comes in many formulations and is prescribed to control blood sugar in patients with type 2 diabetes. This page contains a brief list of metformin medications. However, you should consult the most up-to-date information available because new therapies that may include the drug are constantly being introduced into clinical practice. Metformin is not necessarily a contraindication to undergoing a CT scan with IV contrast, although some patients might need to stop taking their medication temporarily after the injection. According to Bristol Myers Squibb, one of the manufacturers of metformin, IV contrast can cause acute renal failure, which then can lead to a potentially toxic buildup of the drug in the patient's kidneys. Follow your institution's guidelines for post-procedure metformin use. If an inpatient comes to the radiology department with an active IV line, you can't automatically turn off that IV and use it as an access point. Many medications need to be administered at a continuous rate to be effective, including blood thinners such as heparin or cardiac medications such as diltiazem. If you're unsure whether you can use an IV line, consult a pharmacist, radiologist, or radiology nurse. If you do use an existing IV line, make sure you flush the line with saline before and after injecting the IV contrast, and that you reconnect the medication using the same injection rate as when the patient arrived in the department. You must remove the IV line of outpatients who aren't undergoing further testing before they leave the radiology department. First, wash your hands, then put on gloves. Have gauze and tape handy. Loosen any tape over the IV clave, cover the site with gauze, and remove the catheter. Immediately apply pressure to the IV site with the gauze. Don't simply tell the patient to bend his or her arm, as this can lead to a hematoma. If the patient is taking a blood thinner, keep applying pressure. Check for any residual bleeding at the site after a minute. Cover the site with an adhesive bandage if the bleeding has stopped. If there's a little blood, make a pressure bandage with a small piece of gauze and medical tape. If the IV site is still bleeding openly, continue to apply pressure until the bleeding stops. Contrast injection can be hard on a patient's body. Your patient may get a warm, flushed feeling, have pain at the injection site, especially peripheral sites like the hand, experience a metallic taste, or feel a flush in the pelvis. It's important to warn your patient about these common contrast injection reactions. Vomiting is another potential injection side effect. Warn your patient ahead of time that he or she can roll to the side when feeling ill. Keep an emesis basin handy during studies with injected contrast. If a basin is needed, you'll need it quickly. Nausea from injection tends to pass rapidly, and often delayed images can be obtained without moving the patient out of position. Never leave a patient unattended after the contrast injection, even if he or she begins to feel better. More serious reactions to radiopaque contrast media can occur for up to 1 hour after injection. These effects can include hives, dyspnea, and shock. If your patient experiences any of these reactions, or the patient's condition worsens, call a radiology nurse or physician immediately. Radiology departments are equipped with crash carts in the event of a patient emergency. You should know the crash cart's location and be familiar with its contents in case your help is needed during an emergency situation. Most carts are equipped with a cardiac monitor defibrillator, multifunction pads, a resuscitator bag and mask, intubation supplies, and various medications. Your role in an emergency is defined by state laws and your institution's policies. Even if you aren't allowed to administer medications to the patient, you should be familiar with the contents of your crash cart in case you have to assist the physician or code team. You might find several of the following medications in your crash cart. Lidocaine is a local anesthetic used to numb small areas. It also can be used for ventricular arrhythmia. Atropine sulfate generally is used to increase heart rate. Epinephrine or adrenaline opens airways and increases heart rate. Dopamine is a neurotransmitter similar to epinephrine. Sterile water is used to dilute other medications. Dextrose, 50%, is used to raise blood sugar. Aspirin is used to treat suspected heart attack. Nitroglycerin is a vasodilator used to treat angina. Naloxone reverses narcotic effects. Medications such as methylprednisolone or solumedrol reduce inflammation. Antihistamines such as diphenhydramine are used to treat allergic reactions. All scanners have abort buttons on the keyboard and on the gantry. Don't be afraid to stop the procedure if you fear for the patient's safety. It's always worth it. Pushing the abort button stops any scanning in progress and may cause the table to float freely. There also might be safety parameters built into the table, such as an auto stop if an object is in the way. The key to handling emergencies is preparation, and one of the best ways to prepare is to be familiar with your scanner's emergency procedures. This concludes Safe CT Practices. You should now be able to discuss the role of the computed tomography technologist in reducing radiation dose, including technical factor selection, positioning, and shielding. Discuss special considerations for pediatric patients. Describe ethical considerations including the overuse of CT, appropriate imaging of pediatric patients, and how protocols can affect scanning. List techniques used to ensure patient safety, including protocols, venipuncture, and contrast administration. Explain the importance of image gently and image wisely. Demonstrate emergency procedures. This module was created in the style of ASRT Online Continuing Education.